Jakkinaboina, Head Department of Critical Care Medicine at Children's Specialty Hospital, Hyderabad. Welcome to the program. Today we have a distinguished speaker, Dr. Anand Dongre. He is a director, Swastik Critical Care Hospital, and he is also a ex-chairman, ISCCM Nagpur branch. And his area of expertise is ventilation, diabetes, and toxicology. He is also an EC member, and the topic for discussion for today is mobilization of patients and prevention of pressure sores. Sir, over to you, sir. Dr. Anand Dongre.
Thank you, Dr. Srinivas, for a nice introduction. Now, today's program is basically for paramedics and nursing staff. Good evening, everyone. And we are going to talk on a very sensitive but neglected topic of intensive care units, especially the pressure sores, which we usually like to avoid. But because of certain issues with the patient, as well as issues because of the patients which we have, like they are almost unconscious, lying down in coma with sedation. So likelihood of pressure sores are there, and it is a big concern for all of us. Let us find out how the things can be sorted out, a better treatment plan can be planned out, and especially for paramedics and nursing staffs, how should they look for pressure source and intimate SOS or do the preventive measures. First of all, let me tell you that our skin is the single largest organ in the body, and it is like kavach, like it prevents infection from outside sources. So that is why we are healthy and protected from outside germs which are trying to enter our body almost every second of the day. It also protects us from heat, cold, and the elements, which causes a breach in the skin. And the skin helps to regulate the body temperature. It also has the sensation of touch, heat, and cold. So a healthy skin is very important. And once we talk about pressure sore, basically pressure sore is a breach in the skin. And because of that, we call it as a localized injury. And usually the underlying tissue is a bone or bony prominence. As a result of pressure or pressure in the combination with shear, a pressure ulcer is seen. Multiple studies have shown that incidence of pressure ulcers in the ICU ranges from 10 to 41%. Now, what exactly is the pressure sore? As you can see, there are two things. Most of our patients are lying down, and there are postural pressure points through bony prominences. And other point is whenever we keep a patient in ICU, mostly because I keep them in 45-degree reclination, and whenever they become conscious, they try to slide down, and that causes a shear force. So both of these causes a breach in the skin, and the infection ensues. Post-inflammation, edema, and then infection sets in. If you can see, there is just a breach of skin here. The part is reddish and it is superficial. And same thing is here. It is just a healing process. It is a beginning process. So we need to stage the wound so that we know at least which can be a problematic, which can cause complications, and which needs immediate intervention, or which might need a alternate day dressing, wound healing, and other steps to prevent or to treat this sort of pressure sores. As I said here, that category 1, there is a skin which is intact, but there is slight amount of discoloration of skin, there is warmth, edema, hardness, or pain may be present. You just have a look at the patient, turn him over, and try to find out what sort of a staging is this. It's very easy to recognize, but it needs everyday's practice. Like this, the category 2, you can find there is a little blackening of skin, reddish area, the dermal area is exposed, and you can find a slight amount of edema, but not much. So we call it stage 2. Why this staging is important, I'll come to that later on. That category 3, you can find this the same bed sore, uh, but there's sort of a fat which has been involved. The bony prominences are that can be felt, and there is a lot of necrotic or oozing or pus formations out here. So these categories, when subcutaneous fat is visible or bone tendon muscles, they are not still exposed, but slough may be present. So that, and you can see the tunneling as well as undermining. So these are category 3. And category 4, the full thickness involvement with exposed bone, tendon or muscle, slough and eschar may be present, and you can see, you can put, there's a big tunnel out here, and this is bone is visible. Why bed sores are often neglected, or often they are not given much importance? Because the preliminary finding, when we see the patient either usually lands with a respiratory problem, or a patient comes with a unconsciousness, and then we try to take care of the primary or the most dangerous signs, and subsequently then we try to find out what has happened to the other parts of the body. So similarly, if it's just a case scenario, I'll give you that 65-year-old woman was brought in with unconsciousness or ensuing drowsiness, and the history says that she is to live in her village at her home with local care taken by local paramedics. There is history of diabetes, and she is left hemiplegia. You can very well see that she is unable to move around in the bed. She has chronic edema and altered mental status. Although initial diagnosis was made as UTI. Skin was not checked till she was moved to the ward floor. The RMO sees and notifies the attending regarding the skin, and they both decides that it is normal or just a hygienic problem. So everywhere it goes that it is a normal hygienic problem. So next, if we see what happens, and this is this normal? At the glance, you can say that there are a whole lot of issue with whole back, the buttocks, and as well as the lower down portions. There is a lot of edema, and you can see the discoloration. You can see the pus pockets here and there, which are just hidden. So this is not a normal. That is why we need to check every patient who come to ICU with unconscious state or drowsy state, or especially the old people, or from nursing home, or from home care. You must, especially again, one more category which needs to be looked for is neuro patients which are at home. So these are not normal, and this staging, if you do the staging, can anybody just say what could be the staging of this patient, this sore? Chat box, or you can raise your hand. Okay. Can you just ask them to share?
Post in the chat box. Please post in the chat box.
Okay. So this is unstageable because you can see the full thickness issue loss is there, and the base of the ulcer is covered, by a thick skin. It can be the color can be yellow, tan, gray, green, or brown, and the eschar formation can be there. So These are the most, either they are stable or unstable. Unstable means you can see the pus getting exposed or coming out of it. I can show you. I'll show you those kind of pressure source in the subsequent slide. And stable, where dry adherent intact without erythema or fluctuations. You need to find out whether underlying pus pockets are there or not. So this sort of pressure source are really dangerous and cause complications. Epidemiology, as far as pressure sources are concerned, yes, there are almost a million annually adult patients are involved, mostly in ICU and at home, those who are bedridden. Higher risk in older people because of 3-4 areas that their local blood supply to skin decreases because of aging, epithelial layers flatten and thin, subcutaneous fat decreases, and so there is less resistance to the pressure, and collagen fibers lose elasticity. More so, these people they have less tolerance to hypoxia. Thereby, the repair system, the inflammation system, and the edema all together they cause more damage, and thereby the pressure source increase. So we must consider whenever an old patient gets admitted in intensive care unit. Moreover, there is another point to this, that Medicare or insurance do not pay for hospital required stage 3 or 4 pressure ulcers. So we must be careful not to have pressure source in our ICU. Now, incidence, if you find that most of the is staggering, that most of the persons who are brought from home or from home care, they have got 17%, and rather another care which is given in nursing homes, they have got 11%. So, but interestingly, you can find, if you look at the prevalence, stage 1 and stage 2, they are almost 47% and 33%. So it means that at stage 1 it is treatable, and stage 2 also it is quite manageable. So stage 1, stage 2 bed sores are manageable once you know the staging, and once you know that they are manageable, the things, the complications, the sepsis, and further organ damage are reduced. So what we are concerned here with, that those 20% of 3 and 4 stage, which is of little concern, because from the very beginning you need to resort to surgical debridement and other means which I will tell you later on. So how do you assess? One must assess that what is this surgical wound can cause, and what are the risk factors or risk factor of the patient who has come with a different disease, but he has got a bed sores. So the most common risk scales used are Braden scales and Norton scales. And in Europe, they use a Jackson-Gibbon risk assessment score. Braden scale, it takes into a consideration like 5 or 6 categories, almost sensory perception, moisture, activity, mobility, nutrition status, and friction and shear. Once you go for individual scoring, sensory perception, yes, 1 to 4, when no impairment is 4 and completely limited is, especially in those cases with spinal injuries, you need to look for this sensory perception, and especially the old age. So, same with moisture, 4 is rarely moist, so it is good for us. Activities, walks frequently, so less pressures while sleeping or during the day, or during the hospital stay. Similarly, mobility and nutrition, one has to look for nutrition as well. When you find that the patient is cachexic, cirrhotic, liver damage, kidney, acute renal failure, or edematous, those things that hampers the repair system. So they are scored according to the situation which patient has, and then if you see 4, 4, 4, 4, and 4, it means the score goes from 6 to 23. You can see here. And as the score becomes lower, predicted risk becomes higher. It means that if the score is 9 or less, the chances of getting pressure source are high. Similarly, Norton scale, it takes into consideration physical condition, mental status, activity, mobility, and incontinence or continency. And then a scale of below 9 means very high risk. Again, the same thing as the Braden scale. Similarly, Waterloo scale, besides taking all other parameters into consideration, it takes into the neurological deficit or factor contributing to tissue malnutrition as well. And similarly, Jackson Cumming scale, it takes hemodynamic status into consideration. But most followed are Braden and Norton. And Norton was the first to get established in UK for scoring of this pressure source. Who to blame? Now the problem is, if I ask you, 90% of you will say nurses are to be blamed. No, you will be surprised that nobody is blamable for this pressure sore, because there are pressure sore is a disease, is a multifactorial disease, and with a host of the parameters which play and take part in causing a pressure sore. So there is a misunderstanding that the pressure sores are result of poor nursing care. Rather, quality of care does play a role. Pressure ulcers are a complicated multifactorial disease that is often disregarded by medical staff. So what happens when patient comes to us either in lying down position and either on or on wheelchair? Pressure sores are usually found on the pressure points. So a patient who is lying there for more than 2 hours, the blood supply or the capillary refilling stops, and thereby the pressure increases and it causes inflammation, initial inflammation, and then the different stages of pressure sores. So you can find almost everyone knows that these are the prominent bony points which are being shown here, and you can find almost every pressure source in a patient who has been neglected grossly. But most commonly, it is seen here in the buttocks, as well as in heels, and some in the shoulder or behind the skull. On the side, if they are kept for a longer period, then also you can see a single sore on a right or left hip or a part of the limbs. While sitting in a wheelchair, we must take care of this shoulder, buttocks, and heel, and the ball of the. Usually, this is because of the injury with that paddle on which the wheelchair or the person sits and forgets because of loss of sensation, or a diabetic, or an old patient, or hemiplegic. So these are the category of patient we must look for, and we must try to understand the association of pressure sore to their coexisting diseases. Who is at risk for pressure sores? All those who are admitted in our intensive care are at risk, because almost everyone either sedated, or they are post-surgical, or they are on ventilators, they are paralyzed. They are in poor health because of 2 or 3 systems which are involved, and they must be having a coexisting condition, especially diabetic and acute renal failure or chronic renal failure. We must take into consideration. So all individuals, those who are admitted, they are likely to have pressure sores. So one must understand that whenever the patient comes for the first time, you must look at the back or all those pressure areas and try to write down, at least in your note, that there are no bread sore or there is a pressure sore at this particular level with this stage. And that is very important, because almost during the stay, and you must inform the relatives as well that he has got a pressure sore from the beginning. And the causes which we use, the other causes which we use, a lot of devices, especially splints, rolls, abdominal binders, medical tubing, oxygen tubing like circuits, and the clothing sheets, towels, which again can cause air pressure or can cause a shear force, which can cause, initiation of pressure source. So we must prevent pressure or shear to happen to that body which is lying unconscious or in comatose situation. Like here you can see one of the ARDS patient who was continuously on BiPAP for almost a week, and then he developed this nasal sore here. Another risk factors, poor nutrition and hydration when they are brought from home or they are not eating for many days. They are dehydrated. There could be a possibility of acquisition disease, or a patient is admitted with diarrhea as well. Maybe a longer time. Excessive moisture or dryness of the skin. There could be bowel and urinary incontinence, thereby allowing bacteria to move ahead and cause or get through the breach in the skin and causing infection. And exposure to the friction, which probably if the patient is lying for a longer time, then it is a good time for pressure sore to develop. More risk factor, usually the patient with older adults. I just told you that you should take proper care. Moreover, the neurological injuries, neurological disorders, spinal cord injuries, and head injuries, the patient who are lying for a longer time or expected to lie for a longer time, uh, they should be taken proper care, and they should be looked for pressure source every day. Immobility, yes. If individual is not able to move because of certain reasons, either post-surgical or hypoxemic or ARDS or on ventilator or because of some injury, then the preventable or steps to prevent pressure sores be taken for. And every day one should look for, especially diabetics. You can find a diabetic sore. And other those, even though those patients who are conscious but they are on BiPAP, special silicone BiPAP mask can be used. So you can change the device, you can change the protocol, or you can think of changing it to a different mode of ventilation. Sources of pressure can be, especially for neurological cases, diffuse axonal injuries and head injuries. One must look for the scalp as well. You can see it can develop, a pressure sore can develop here as well. So the plaster casts which you use, oxygen tubings, anti-embolism stockings, one must every day. I mean, I'm just requesting every matron or head nurse who are present over here that to every patient in the morning, whenever they come and they go and see the patient, then they must ask them to turn over, look for each and every time pressure sore point whenever the patient is lying down or unconscious. And in that way, they can check and they can find out whether the pressure sore is being developing or whether it has developed and nobody has noticed. It should be notified to all superiors as long as you want to keep that patient, not going in complications, thereby giving rise to a threat to death. Septic shock, sepsis, septicemia, multi-organ failure can develop with this type of pressure source if they are large enough. And because the infection, skin infection, they happen because of certain poor skin hygiene, poor housekeeping practices. So you must change that. Long-term use of antibiotics also predisposes to resistance of bacteria and thereby causing infections. Germs transmitted from the local areas as well as buildup of bacteria and other germs on or within the skins. So they get into the cracks or breaches which has caused in the skin because of the pressure and thereby cause infection. Pressure. So you can see this child was bedridden for quite a long time because of the contractures he has developed and unable to move his joints. So he got such a big pressure sore over here. So bedridden patients should be taken care of positively for pressure sores every day. And similarly, protocols needs to be changed if you find that a bed sore is developing. So every day he might will complain you that I'm having pain over here, over the nose. But you know that a BiPAP mask is necessary for him to keep the oxygen up and to prevent further hypoxemia. So we can change this to HFNO. As you see, he has started developing a pressure sore over here. So it has been changed to HFNO. So you can alternate protocols you can manage and provide to the patient, positioning of the patient. And that is where we must, keep special attention to. I mean, all the chief nurses, I request them to find and to try to correct the position change. As you can find here, there is a pressure source developing here. She is lying in a very incorrect position so far as pressure source are concerned. So the use of pillows, the use of proper bed, I will come to that. And again, using of devices. So once you use a device, the orthopedician comes and he will tell you that you have to keep these devices on, but you need to check them every day. Open this up, check whether there is a pressure source developing or not. And old age people with pneumonitis or respiratory failure, once they are off BiPAP or they are on intermittent BiPAP, they must be assisted and asked to sit or to move their legs so that the circulation improves and chances of getting pressure source are reduced. The steps for prevention, for checklist for those sisters or who are in charge. I mean, you must check for incontinence, the position of the catheter, changing of a soiled brief uh, every 2 hours. Ask them to see at least every 2 hours or hourly, or if the patient is passing a lot of motions at a regular interval or irregularly, then you must check it by yourself, because he is not going to tell you that motion is being passed. And never use double brief, because that again takes away the purpose that you leave the patient with that dirty position for a longer time. And the more time it happens like this, the chances of getting pressure source are high. So position properly and 2 hours. This must be done to prevent pressure sore at all, especially to those who are unconscious or on ventilator. And please wash your hands before touching the patients. So remove soiled briefs, wipe from front to back. I think everybody knows about it. And apply barrier creams. There are various creams which are available, but you must do according to your consultant who is going to brief you on that. And make sure that all the position, all the surfaces are flat and dry. Repositioning. If patient is becoming conscious and again he's changing he's unable to change his position, was trying to, then you can reposition him. If in bed, at least 2 hours, every 2 hours you should change the position, either side to side. Then you can use the pillows under one side of the back and then reposition again, and the pillow on the opposite side. I think most of the intensive care now has learned to do this change of positioning and placing cushion support under feet and ankles. But here again, many of you might have seen that people just they fill the gloves with water, and they try to keep those under the heel or the knee. But that that is a wrong practice, because gloves kept like that cannot distribute the force. Whatever we need something which can distribute the force. And for that, we have got silicone gel sheet which can be used for that. Now the question of mobilization comes. Whenever mobilization comes, mobilization helps a patient in many ways. That first, increasing the circulation, and second, uh, for a better respiration and a better repair system. So our repair system requires a continuous blood flow and a continuous oxygen supply. And in both, most of our patients, these both things are not adequate. So we must try to mobilize the patient, especially the surgical patients, as early as possible. So even with oxygen, so that these things helps in repair of the system. So early mobilization, what does it do? It decrease in days of delirium. Delirium is very bad in ICU, and almost 15 to 20% death rate has been reported. So we must avoid it. If you just think about yourself, that if you are lying in a bed for days and nobody is allowing you to at least make you mobile, that keeps making a certain thought going in a patient's mind, and then uh, uh, he will become irritable, he will become uh, his behavior changes, and then he will stop taking feeds. So all these things we have to prevent for as far as pressure source are concerned. And increase of functional status, yes, if the functional status increases, he eats better, he eats more, and he is mobile, his circulation improves, his hypoxemia improves, and thereby the chances of getting pressure sores are less. Decreased hospital stay and ICU length of stay, it has also shown to decrease. And decreased mortality, especially where the patients are mobile, move early from their beds. So early mobilization, even in wheelchair, this patient was just a brief history of his. Like he was a diabetic, he was in diabetic ketoacidosis with right pneumonitis, and he was unconscious for 5-7 days. He was on BiPAP, sometimes on ventilator. Got up, but blood sugars were still not getting to the point which we wanted, and he started showing early signs of pressure sores, especially in hands, scalp, and although he had a lot of mobilization done earlier as well, but he was taken out for some time. He was happy, and he says, "This is what I wanted for." And from that day onwards, he started improving in a better way. So early mobilization, either in company or alone, you can give them mobile. You can ask them, you can engage them so that they can keep on, trying, or they keep on asking for mobilization frequently. And every 2 hourly, 3 hourly, or every 6 hourly, you can move them on wheelchair, and that can help them to prevent bed sores. So ideal prophylaxis dressing, as I told you, is a soft silicone foam dressing, and what it does, it redistributes shear, redistribute pressure, reduces friction, and maintain an optimal microclimate. But the the cost is a little concern here, and you can just use those pressure points when the patient is lying down to in a small area. You can use them. And again, proper skin care has to be done. Inspect skin daily, as I told you earlier. And for any change, you can report to either your surgeon or to your consultant intensivist or to your immediate doctor who is on the rounds. You must inspect for wrinkles and folds in the bedding, and the clothing which can irritate the skin and can cause pressure sores. Incontinence, again, if they're catheterized, then you must check the position of the catheters. You must check whether it is leaking. You can change the catheters. You can also think of every 2 hours whether they are soiled or not, and that helps in preventing the breakdown. But never use double diapers. And another important point is, when washing, use a soft sponge and or cloth, but don't rub them. Use moisturizing cream. Keep the skin moist and clean and dry, especially under breast and groin. Do not use talcum powder or strong soaps, or do not rub the skin. Uh, as far as proper skin care is concerned, just you can rinse them with mild soap and warm water, usually once in a day, and then keep on applying lotions and ointment as prescribed. Uh, if there is a pressure sore, then you can use antibiotic, especially metrogel gel, which can take care of almost anaerobic and bacteria which can get in. You can use a combination of gram positive, gram negative uh, ointments, or you can think of just using growth factors. If you think that skin sore is infection free, you can use, there are a lot of growth factors which are being used and available. And but never leave that the pressure sores uncared for, and you must put a dressing on. Again, don't massage the skin area which you feel that it is wrinkled or red or edematous. Supports, yes, everyone knows about the air beds, special air beds which can be used. There are wedges, cushions, and pillows which can be used while doing the positioning. Make sure that they are done almost 2 hourly every day. Other modalities of treatment of pressure source, yes, there have been a lot of modalities which have been in use, or they have been used, they have been tried, like the ultrasound waves at 3 millimeter Hertz unit. It proposed to be the most effective frequency, but still it is not been taken very well all over the world. Second was electrical stimulation. It has been advocated over the years for enhancement of wound healing. Third is pulsed electromagnetic fields, which are relatively new entity in the wound care, and specification include use of a frequency of 27.12 megahertz. But again, we have to see how things move on this regard. But the most important development which has taken part in last 3 years, and it has been used uh, very frequently, is the use of VAC, or vacuum assisted closure. And this has given us, like those big wounds which are having necrotic tissue, or a pus area, or the pus, the frying pus which is coming out. You can just, before debridement, put them on vacuum suction, or you can debride and then put them on vacuum suction, keep them for 24 hours and 48 hours, and marvelous results have been found with vacuum suction. So this modality is going to be very soon adopted uh, in most of the wound care systems where wound cares are taken care of. Then wheelchair also should be taken care of. You must look at the wheelchair, inspect it daily, clean, especially the cushions for signs of wear, inflation, or proper placement. Inspect brakes, armrest, and floor rest. And if needed, they should be sent for repair. Otherwise, the patients are going to be in trouble. Not only that, you have to take care of the nutrition. If the patient is awake and he can eat food, then you can improve the protein quantities. You can add zinc minerals, which are usually deficient in these patients, and especially zinc and chromium, uh, which can be given them either IV or through rice tube. Or I know the intensive care loves feeding, to parental feeding. So there are a lot of formulations and things which are available to supplement each one of them. But you must make sure that you call a dietitian, ask for a diet which is high in protein, and um, which can help you in preventing or treating the bed sores. Third important point is good hydration. Other whenever you are feeding the patient, or if the patient is on IV supply, then you must make sure that adequate uh, hydration is given. Now, complications. Why we are worried that pressure sores are there? What would do? Pressure sores gets complicated, and they invite sepsis, local cellulitis, generalized edema, acute renal failure, hepatitis, respiratory failure, unconsciousness. They can involve any systems, any all other systems like a sepsis. A overwhelming sepsis cannot be just can take you by surprise if such a big bed sores are there. So we must do an urgent intervention for this, and it can cause even death. These are all life-threatening infection. The amount of infection, once you look at the sore, it may not be here only, but once you debride this, you can see a bigger area is involved besides the skin only. So one must do early debridement if needed, vacuum suck if needed, and especially important is positioning of that patient and preventing getting patient source to your normal patients, and that should be your aim. Because treatment modalities are there, but they are not as effective as the only one modality, which is prevention. So early detection and prevention are lies, or the onus lies with the first person who comes with their contact is nurses and paramedics. So they should take care that every day they must look at the back, that they must look at the pressure points and find out if there is a little redness, little edema. If they detect early, the pressure zone won't develop and won't become big and won't threaten the life. Documentation is very important about the pressure source. This is one of the problems that whenever you get a patient, you must clearly say or write that whether he has got a pressure source brought from home, and if it is there, then what did you do, whom did you contact, what instructions were given, did you implement the instructions. I mean, in 24 hours, these all things should be done every day. And if the results are not effective, if the pressure source is not decreasing, then you must inform and get a surgical opinion, or you must go for a vacuum suck, or you can go for debridement. But unless you tell, unless you notice, unless you document, the pressure source will give you a surprise. When it becomes big, the sepsis sets in. So this is the checklist for every day. Just you have to write that this is one of the form which you can just keep in your ward, and just ask your sisters to say, write, tick yes or no, whether you have consulted your own team, whether you inspected it daily, whether you have repositioned them, each and every patient, and whether there any distributing devices being kept, nutrition status has been assessed, dietitian has seen, and proper care to already existing pressure source are given or not. So once you do the checklist, at least most of the pressure source, I hope, can be prevented. Most important factor we often do not mention when we put a diagnosis, we just write pneumonitis, but coexisting factors or respiratory failure will not help us. Diagnosis must be inclusive of a coexisting condition of the patient. And once you look for diagnosis and you find that a diabetes is there, then you should be doubly sure that this patient is going to develop uh, uh, the pressure source. So you should be more careful, especially again the smoking history if it is there. So all these coexisting conditions or neurological condition should be mentioned and should be underlined for on everyday's flow sheet whenever you look for or go for a patient. And these are important. Just before I leave you, I'll just show you. See, we have grafted this wound. He had got a multiple areas which were involved. At least two wounds are seeing there, and two wounds are here also. So we grafted this. It was on vacuum. Then we grafted, and it is healing. But another curious problem is there, which is lying here. This looks small, but you can see the video. Almost 300 to 400 ml of pus which came out. He's a patient of spinal injury, was at home post-operatively, and came back with respiratory insufficiency, hypoxemia, increasing drowsiness. And this is how even a small looking wound can have a lot of sepsis inside. So we must look for that, and we must pay attention to pressure source every day. Thank you all for apt attention, and over to Srinivas. And if there are any questions, they are welcome.
Yeah, thank you, sir. It was a great lecture. Actually, very interesting, but very less observed by the people. But I think nowadays the NABH and JCI has put a norms to monitor these pressure ulcers as a quality indices. So, any questions? Should we use? One question has come. Please post the questions. I would like to uh, share my experience in our hospital. So I'm a infection control chairman for our hospital. So what I have done is these infections, especially in a, I have concentrated on patients where patients were bedridden in the ward and all the ICU patients. What is the what is the plan? Is every second hourly we change the position of the patients. Okay, other than the unmobilized patients. So we will have, if you look into the checklist, there will be a checklist for the pressure ulcer. So most of the people, what they used to do is any checklist when it is there, they have to either tick yes or no. So without checking the patient, they used to check. Okay, and next what happens is We have put a clock into our ICU and into the ward. The 10 a.m. to 12 p.m. this is the position. 12 to 2 p.m. this is the position. So they used to tick in the chart saying that this patient is in the right lateral position. But when we have looked into the patient on the chart, the position is right lateral, but the patient is in the supine or in the left lateral. So this discrepancy was there. That means the healthcare workers, whether a doctor or a nurse, I don't want to blame only nurse. So whether a doctor or a nurse or other healthcare workers, they are not looking into the patients, whether which position the patient is in and the which position the patient is charted. So initially we had a discrepancy approximately 40 to 50% discrepancy between the chart monitored and the patient position, real position of the patient. So we started looking into this, and daily we are auditing, we are updating the nurses, we are updating the healthcare workers, we are updating the doctors. And I think in 2 months' time, we have seen that the pressure ulcers has drastically come down. So, so that we all at present we don't have any pressure ulcer problems in the ICU or in the not a major problem in the ICU or in the ward. I think these type of audits and check systems has to be there in the hospital to improve our things. Of course, we cannot prevent 100%. As sir mentioned that we have to follow all the processes for the prevention, but it can be, it can, anything can be never zero in medicine. Okay, always there is a scope for improvement, and I think we all has to audit it, discuss in the infection control unit, and a lot of nurses, new nurses will be auditing into the units, each of the units. We need to train them. Training, and implementation and auditing. This also goes for the improvement in your IC. This was I thought this experience I would like to share. So one question to you, sir. Coconut oil can we use for back care?
Okay, I think it comes from Kerala.
Not always, sir.
Coconut oil is healthy to eat,
Yeah, yeah.
but whenever pressure sore is concerned, we try to avoid those things which are sticky. So a patient who is lying down in unconscious position, we try to prevent the use of oils. So mostly the gels are preferred, and the moisturizers are preferred, which are meant for uh, other than oil. So I feel coconut oil is not to be used. Yes, when you are alive, kicking, and you are moving around, you can use it well as well.
Yeah, they already replied from Maharashtra. The person who was on. Yeah, sir, one question to you. You have said that first degree, pressure ulcer, first stage pressure ulcer, you have seen almost 47%, and second stage you have seen 33%, and third and fourth we have seen in 20%. So, where the pressure ulcers are more, whether in the hospital sector or a nursing health
No, no,
sector,
these are these.
or in
So
in
see,
the patients who are taking it home.
yes. So most of the patient, those who are reported from home or from a home care sort of thing, they reported a higher degree of stage 3 or stage 4. But in hospital, usually because of everyday's check, or because of their improving conditions, or because there is the other intervention, we almost see 47%, or together they almost cause 70% of stage 1 and stage 2. What I was trying to say, that if you catch them at stage 1 or stage 2, the prevention and further treatment is better than going for stage 3 or stage 4.
Yes, sir. Any more questions, please? Please post. If a patient on mechanical ventilation and not in position to change him, so what we can do? One question. The patient is on mechanical ventilator and not in a position to change him. What we can do?
Change him means what? I mean, the patient
Position
is lying
change.
down. Yeah, patient is lying down flat. He has got a tube and is attached to a circuit. So you can put him in a lateral position or either of the lateral position and the a supine position. You can use air mattresses. You can use soft cushion gels, uh, especially under the pressure points which are there. Suppose he is lying down in a supine position for a longer time, then you can use those gels. But every 2 hourly, you can have either of the lateral or either of the lateral positions. You can change them. Is there a problem in changing the position?
Sir,
I mean, the question.
yeah, there won't be any problem in changing a patient on a mechanical ventilator. So we can change the position even the patient is on high PEEP also. But take care that the tubes should not come out. Take the help of a doctor at the time of changing the position. One, and even we put the patients on a prone ventilation also. So changing the position should not be a problem. One. Uh, Second thing is the pay. Probably a nurse who has asked might be a spine center where they might be doing having a fracture spines and patients on ventilator, prolonged ventilation. I think maybe that sort of things. So it is yes, sir.
Even if it is a fracture and whether it depends whether it is operated or not operated. If it is operated more than 24 hours, I think one can give a little tilt to either lower body or to the upper body and then keep on putting a cushion at the back so that patient, at least part of the patient's body, gets aerated and gets out of pressure. I mean, the pressure points are relieved. So
Yeah.
you have to judge according to the patient, and even it requires a teamwork. Uh, Maybe you can keep a time that at 4 p.m. The team will start changing the positions. So by 6 o'clock, everybody's position is changed. So this way you can have, and especially if you are changing a patient on mechanical ventilation, so someone can hold the tube. At least one person keeps holding the tube only, and the three persons they can change the position.
Yes, sir. Agree, sir. And one more question has come. Sometimes after surgery, complete immobilization is advised. What we can do in that case? So
Yes,
this,
go ahead.
yeah. So basically, this type of, as previously discussed, the spine surgeries. Usually, after fixation, there should not be any problem in changing the position. But at the same time, discuss with the surgeon, uh, saying that this patient has to be position change to avoid pressure ulcer, and he will also tell you the how to change the position because these are delicate patients like spine surgery patients. So you can take the suggestion of the concerned surgeon and then you can take change the position.
Yeah, and by the time 24 or 48 hours are over, till then you can, as I said earlier, put him a little lateral position, put the cushions inside. You can put soft gels, and you can manage those pressure points. Then also it's okay. Any more questions?
So pressure ulcer is one of the dangerous thing actually, and identification also is very important because sometimes what happens is patients may develop fever, and as sir mentioned that there is a very small pus point sort of things will be there, and inside the deep there will be a big pus will be there. So these type of things you may not always see a broken skin. So you can also look into that. Sometimes the pus accumulates inside only, and so that you have to examine daily. Is there any pain in the buttock or in any of the areas? There is any pain, redness, or patient having a fever? You need to check into these things because these are the one of the most common things which are missed. And daily, 100% these are in every 3 shifts it is checked by a nurse. Doctors may check only once per day. This is my suggestion.
And this becomes a medical case, like a patient gets transferred from another hospital, and you find that already bedsore which was there, if you don't mention it and you don't intimate the family, and ultimately if the patient dies because of that pressure source or septicemia, then things go bad.
Yeah, always, sir. I think we you also might be doing that. The in emergency centers, in emergency area, whenever they come into the emergency, they if the patient is having any pressure or ulcer, so initially they document it, and if the patient is transferred to the intensive care unit also, we document it. We take a photograph of that, and we even show to the patient family members at that instant only the pressure ulcer is present, because tomorrow we don't want any conflict with the family member.
Yes, true. I think no more questions.
Yes, sir.
Sumit is there. Can we close down now?
Yes, sir. I think it is down, and
Just
so thank
ask
you.
anyone.
Any question more? Any more questions? We'll wait for 2 minutes, sir. Another 2 minutes
Okay.
is there.
You have got neuro cases as well.
Yes, sir. We have neuro cases also.
we
Uh,
we we find that lot of patients who are being specially diffuse axonal injuries, those who are sent home, they
hmm.
come back with lot of pressure sores here and there,
Yes, sir.
and those are the real trouble because the brain is not working, it is
Hmm.
just coming out. Maybe he started opening his eyes, and things go worse. So those are the cases which are that they undergo anesthesia as well for debridement, but lot
Good
of
thing
use
is,
of microsurgery.
sir. Good thing is now a lot of rehab centers has come in
Yes,
Hyderabad.
yes.
So
Okay.
most of the people are joining there, and they are having a very good rehabilitation and anti-mobilization injury, because most of the hospitals where we are treating in acute centers, rehabilitation is a problem, especially in the ICU or in the wards, because most of the patients are filled with inpatients, and they don't have any room for rehabilitation, and they don't have time to rehabilitate also. So a lot of rehabilitation centers can do a better job. Yeah. Yeah. Thank you all. Thank you, sir, Dr. Anand Dongre, for giving an excellent lecture on mobilization of patients and prevention of pressure sores. And I thank ISCCM and also all the delegates for your active participation and learning from Dr. Dongre. Thank you all.